Welcome to this medicine masterclass in which we will be discussing congenital heart disease. We will focus on ventricular septal defects, atrial septal defects, patent ductus arteriosus and tetralogy of Fallot. Let's start with VSDs. A ventricular septal defect is an abnormality in the septum between the left and right ventricles. This is the commonest congenital heart defect, but VSDs can also be acquired. Congenital can be isolated or part of a wider congenital condition such as Tetralogy of Fallot. Tetralogy, which we'll discuss shortly, also has pulmonary stenosis and overriding aorta, right ventricular hypertrophy and the presence of a VSD. A VSD can also be acquired, particularly post-myocardial infarction, resulting in sudden hemodynamic collapse. VSDs are associated with PDAs, patent ductus arteriosus, aortic regurgitation, as well as endocarditis. The signs of a VSD are the presence of an ejection pansystolic murmur heard between the pulmonary and tricuspid areas, radiating to the apex and the back. Interestingly, larger defects create quieter murmurs as the flow passes easier between the ventricles, causing less turbulence. A very loud pansystolic murmur of a small ventricular septal defect is known as maladie de Roger. Be aware of Eisenmenger syndrome. This is where a normal left to right shunt that occurs in VSD eventually causes the pressure in the right ventricle as a result of compensatory remodeling to exceed the pressure of the left. And as such, a reversal leading to a right to left shunt occurs, resulting in cyanotic heart disease. The main signs are an audible murmur with cyanosis and clubbing. Signs of right heart failure such as peripheral edema and raised JVP will also be present. Although Eisenmengers can arise, small VSDs may be asymptomatic, but other complications include heart failure and an increased propensity to developing endocarditis in larger VSDs. So to manage these patients, congenital VSDs 30 to 50% close spontaneously. However, if there's a significant left to right shunt or increasing right heart pressure, then surgical closure should be considered. Let's move on to atrial septal defects. An atrial septal defect is a defect in the septum between the left and the right atria. The signs may be similar to pulmonary stenosis but not as harsh. So that's a soft ejection systolic murmur, loudest at the pulmonary area, but this radiates to the back and characteristically results in a fixed splitting of S2. And the patient may develop signs of right heart failure. There are three key types of an atrial septal defect: a primum, secundum, and a sinus venosus ASD. Primum is 15% of cases. It's the most inferior defect occurring just above the atrioventricular valves and is also known as an atrioventricular septation defect. And it occurs due to abnormal development of the endocardial cushions. It can be associated with a VSD as well, and on an ECG you'd expect right bundle branch block with left axis deviation. A secundum ASD is the commonest type of atrial septal defect and is due to a defect in the central fossa ovalis. And in these cases, a right bundle branch block is present with right axis deviation. Sinus venosus is 15% of cases and is a defect in the folding of the atrial wall near the superior vena cava, and this results in SVC communication with both atria. The management of ASDs is symptomatic ASDs should be surgically closed, as well as those that result in paradoxical embolization, and asymptomatic patients with significant shunts or the development of right heart pressures or pulmonary hypertension also advocate surgical closure. What about a patent ductus arteriosus? So this is a patent embryological connection between the left pulmonary trunk and the descending thoracic aorta, which usually closes at birth. If untreated, a large patent ductus arteriosus can result in Eisenmenger syndrome in childhood. The signs of a PDA is a continuous machinery murmur associated with a collapsing pulse and a wide pulse pressure. The patient may develop signs of pulmonary hypertension or cor pulmonale. That would be a loud P2, a left parasternal heave as a result of right ventricular pressure increasing. The management for these patients are usually required for symptomatic patients or those who have gone on to develop Eisenmengers. And just to discuss Tetralogy of Fallot, Tetralogy, as the name suggests, has 4 key features: pulmonary stenosis, an overriding aorta, a ventricular septal defect, and right ventricular hypertrophy. The signs of these patients, so this is a congenital heart defect which requires early repair, and is repaired usually using a shunt known as a Blalock-Tassog shunt. This is a procedure designed to increase pulmonary arterial blood flow in patients with right ventricular outflow tract obstruction, and it involves the joining of the subclavian artery to the pulmonary artery. And so these patients may have a left lateral thoracotomy scar, they may have a radial pulse defect where the pulse is weaker on the side of the shunt and the arm on the shunted side as a result may be underdeveloped. And you may also see a stenotomy in patients who have had a complete surgical repair of these 4 features in Tetralogy of Fallot. Some of the complications that you should be aware of are patients can develop regurgitation of any of these valves, and they may require a permanent pacemaker if they develop atrioventricular block or for refractory ventricular arrhythmias. Associated conditions with Tetralogy of Fallot: be aware of DiGeorge syndrome, where you have abnormal faces, that's a cleft palate, could be repaired, along with a long face and low set ears, and Poland syndrome, where patients have the features of Tetralogy of Fallot as well as unilateral pectoral hypoplasia. Thank you for attending this medicine masterclass.